My name is Barbara Minkowitz. I'm the Medical Director of Pediatric Bone Health for Atlantic Health. And this is our 7th Pediatric Bone Health Day seminar. I'm going to turn the mic over to Katie Mott. She's going to start off talking about nutrition, and then I'm going to come back and do a vitamin D / bone health update for 2022, since a lot has happened since my first lecture in 2018. So here you go.
Thank you, Dr. Minkowitz. Just going to put this guy on. All right. So thank you guys so much for coming. My name is Katie. I am a registered dietitian, and we're going to be talking about pediatric nutrition for bone health and beyond. So just a little bit about me. I'm a registered dietitian, which means that I have a bachelor's and a master's in nutrition. I'm also a registered yoga teacher, so I kind of like to put that fun fact in there about myself. Right now, I'm the coordinator of the KidFit program. So it's a counseling-based program for weight management, focusing on optimizing activity and nutrition for children ages 3 to 18. So run through the Department of Pediatric Endocrinology in Morristown. So what are we going to talk about today? So we're going to talk about, I wanted to break this up into kind of, 2 or 3 different sections. So we're going to talk about basics of pediatric nutrition for children and teens. I think that's very important for, kind of putting into context the importance of bone health. We're also going to talk about strategies for promotion of a healthy weight. And we're also going to talk, of course, about pediatric bone health and nutrients of importance. So pediatric nutrition basics. So we're going to talk about the what, the when, where, and the how of feeding children. So we're going to talk about foods to focus on, foods to avoid. We're going to talk about feeding environments and schedules. And then we're going to also talk about how do we feed, how do we talk about food and eating around kids, and how does that impact them. So what? So nutrients and foods to focus on. So I don't necessarily like to, group foods into good and bad categories, but I like to say, what foods should we be focusing on generally for kids? So I broke this up into 2 slides, so I have this one and another one. So you can see there's different nutrients of importance that we want to focus on specifically for kids. And it all really kind of revolves around this idea of building a healthy body. So what nutrients do we need in order for kids to support their growth, to make sure that they have essentially all the ingredients that they need to build their bodies? So protein, of course, being one of them, very important for muscle growth and development. Also important for, as we'll talk about a little bit later, calcium absorption and bone health. So where do we find protein? A couple sources there. Calcium, of course, again, comes back to this idea of building a healthy body. We need calcium to build bones. It has other functions as well. So, very important that we focus on calcium also. Iron, very important for building bone stores or iron stores. So very important to think about where kids are getting iron and what those iron-rich foods are. Fiber also too, very important. I do see a lot of kids with constipation, with digestive issues, so not necessarily something that we always think about with pediatric nutrition, but something that I think that we should. So what are our high fiber foods? What are our good sources of fiber? And are we having kids incorporate these into their diets on a regular basis? So a couple other things to focus on, of course, vitamin D, vitamin C, and healthy fats. So vitamin D, of course, important for bone health, important for many other functions in the body, including neuro and immune health. So thinking about, what are our high, good sources of vitamin D, and are we getting them into kids' diets? Vitamin C, of course, also important for bone health, important for building a collagen matrix, important for immune health. So, thinking about not only what are our sources of vitamin C, but are kids getting these in their diets? Healthy fats, of course, not necessarily something we always talk about with pediatric nutrition, but something that I think is important to talk about and to focus on. So where are our sources of healthy fats? Avocados, olive oil, fatty fish, eggs, nuts and seeds, things like that. So what should we be thinking about limiting? So I don't necessarily like to say that any foods are bad. Kids pick up on this idea of good and bad foods. And also, like adults, we kind of assign value to foods, and we think that we ourselves are good or bad for eating those foods. So we like to think about what foods should we be limiting. So really this idea of calorie-dense, nutrient-poor foods. So things with added fat, sugar, sodium, 1, 2, or all 3 of those things. So we really want to think about foods not only that are, high calorie, but also are nutrient poor. So some foods have more calories, but are very nutritious. Some foods don't necessarily have a lot of nutrition, but aren't necessarily calorie dense. So we want to think about, what are the foods that we are having that maybe are calorie dense and nutrient poor. Sugar sweetened beverages. It is not a mistake that I put that on there 3 times, because that is the only thing that I really encourage the families that I work with to really actively limit. Sugar sweetened beverages really have no value. It is very easy to overconsume them. So I really think it is very important for us to be conscious of how often kids are having these. And of course, I don't only mean soda, but I also mean juice. I mean sweetened iced tea, lemonade, things like that. Very important to, I think, be conscious of that. And the American Academy of Pediatrics, of course, recommends limiting fruit juice. 1 to 6 years, we don't want to have any more than 4 ounces per day. And from 7 to 18 years, no more than 8 to 12 ounces per day. So that's really a very, pretty small amount when you think about it. Really a half a cup to 1 cup per day. So this is kind of like a way that I like to teach, sort of like the concepts of foods to limit and foods to include in our diet with young kids. I think this is an easy way for them to sort of visualize it. So I teach go, slow, and whoa. So go foods are our green light foods. So these are foods that we can have in our diet, most or all the time. Our slow foods are sort of our red light or yellow light foods. So these are foods we can have sometimes, but not all the time. And of course, our whoa foods are sort of our red light foods. Those are foods we really want to focus on limiting. So you can see I have like a little, there's a graphic there, and you can see kind of like which foods fall into which different categories. So it's all about how you phrase it. It's about your attitude around foods. Another way to phrase it is some foods do a lot for us and some foods only do a little. So kids kind of pick up on, what sort of ideas and values we assign to foods. So very important that, we, do try and actively encourage those healthier foods while being conscious of limiting those foods which don't do a lot for us. Yes. Yes. You can find this on the web, but I'll definitely send it out. Yeah, we can send it out.
I've never heard it before.
I love go slow and well.
Yeah.
Don't get me started on go slow and well. Sure. Depends on the kid. So really the answer is if they don't have a weight problem and they don't like to drink water, I would say definitely they need to work on increasing their water intake. Because what I say is, like, the sugar sweetened beverages aren't good. So of course we should be limiting them. But you should really treat, the sugar-free beverages the same as the sugar sweetened beverages, because in essence, you're not necessarily replacing them with a better substitute. You're just kind of eliminating the sugar, but you're not really getting anything in return. So usually what I say to families who are struggling to kind of like increase hydration, maybe trying to cut out the sugar sweetened beverages and not include the sugar-free beverages, is to focus on anything else that they can drink besides water. So infused water, yes, seltzer, absolutely. I think flavored seltzers are great. I think flavored seltzers are great. Flavored seltzers, flavored waters. Hint water is a great one. It's 0 calorie. It just has some natural flavors added to it. Things like Crystal Light, again, not the best substitute, but I think really trying to find other alternatives that aren't soda or sugar-free beverages. Yes. There's a lot of variability. So there's a lot of companies have a lot of leeway, so to speak, in what is considered a natural flavoring or a natural additive and what is considered an artificial additive and flavoring. So really, when you see natural flavoring on a label, it doesn't necessarily mean that it's natural at all. So, but you guys probably already knew that. So, or suspected. Yeah. Oh, I hear that all the time. Absolutely. Well, you have to, to a certain extent, you need water, So I think also trying to explain why water drinking is important can help kids, especially teens, sort of understand, hey, this is really important. And sometimes I come at it, at a not so subtle approach. Like I do have other motivation. So I'm like, with our teenage girls, I say, water is great for making sure that your skin is clear, making sure that you have lots of energy. With teenage boys, it's a little bit more difficult, but, making sure that it's something that they can kind of connect to. So that helps a little bit. So trying to find their motivation, Yeah. Yep. Yeah.
I'm going to ask. Thank you.
Yeah, I'm not sure. And honestly, I feel like it depends on the person too, what does the rest of their diet look like? What are they eating and drinking? what are their obviously medical conditions, things like that, you know. I mean, like they can try, you know, I try and work with kids and see like, well, hey, like what would help you drink more water? Like what would help you like, you know, increase your hydration? Can we set a goal for your hydration? And of course, like anything that they can add to it, if they can add like if they like sliced strawberries, like slice up some strawberries, crush some strawberries, put that in there. Slice lemon, slice cucumber, slice oranges, like anything like that. And yeah, like watering down some things, you know, other beverages with water can help too, you know, all depends on where a kid's at, you know. But yeah, it's a tough challenge. And I think, you know, a big part of that is because kids are used to drinking things that are very sweet, you know, so water just doesn't taste good. Yeah. So whatever gets them to drink less soda and juice and more water is, you know, a beneficial thing. And you have to think about like long term, you know, sometimes it's like, okay. All right, let's I'll move on.
We take that.
That's all right. This is what I teach to the younger kids. So I do teach my plate. I think it's an easy visual for younger kids and for families to understand. So, you know, of course, quarter plate grains, quarter plate protein, half a plate fruits and veggies. So, you know, I always say it's okay for half your plate to be veggies, not okay for half your plate to be fruits. So we do want it to be kind of a mix of both. And also what I try and focus on and what I try and teach kids is protein, carb, color. So if we have a carb on our plate, that's good. It's going to give us energy. Our protein foods obviously are going to give us energy and keep us full. And the color is going to kind of cover the fruits and vegetables. So if kids aren't great veggie eaters, you know, trying to at least include some type of colorful food at meals gets them used to the fact that that does need to happen. So just some considerations for different periods of growth. So, you know, when we're thinking about nutrition, a lot of nutrition, of course, is, you know, in context. Young children and toddlers, obviously, more of the focus needs to be on protein foods, on healthy fats, on development. Sometimes their portion sizes can be smaller, so their meals, of course, may be a little bit more frequent, so that's okay. School-age children, 6 to 12 years, period of slow but steady growth. So, you know, they're going to be developing their preferences, their ideas about what they like and don't like, and their own schedule. So important to sort of pay attention to, you know, what their preferences and ideas are at that age also. Adolescence, of course, is a period of rapid growth. You know, really, because of the rapid growth, we have a big focus on calcium and iron requirements, especially in females. And of course, they have more influence from their peers. They can have, you know, their own ideas. They're going to have their own money. They're going to go out and buy their own stuff. So additional social challenges there. So the when and where of eating. So I just like to touch on this because it is very important. Creating a positive eating environment is a very important thing for kids to associate meals and eating with a positive experience. So avoiding arguments and criticism as much as you can, serving meals at the table as much as you can, and trying to stick to a schedule for meals, especially with young kids. You know, our lives are busy and some of this isn't always going to be feasible. But I like to say, like, to the families that I work with, if you can have one meal a week or even one meal a day, if it's breakfast, maybe it's an after school snack, maybe it's dinner, if you can eat together, that's going to have a positive impact on your kids. So, you know, trying to you know, functionally practice that is very, very important. And of course, minimizing distractions at meal times. So, you know, encouraging mindful eating is a part of this. So, you know, not only putting the cell phones away, putting the iPads away, but also turning off the TV at meal times. So really trying to be present at meals, not only that, you know, helps kids to tune into their own hunger and fullness cues, but also helps everyone to be a little bit more present at the meal and pay attention to their meals and to each other. So I think, you know, very important thing that I like to talk about with families. So how do we feed? How do we talk about food and eating with kids? I really like to use Ellen Satter's division of responsibility with feeding. So Ellen Satter is a registered dietitian. She's also a social worker. She's written a lot about feeding kids and the development with feeding kids. She has a couple of great books. But basically, she has an idea of, you know, this idea of different jobs at meal times. So children are responsible for what to eat and how much to eat, and parents are responsible for what's served. So if you look to the right, I did make a little graphic there. So kids can ask for whatever they want at meal times, right? And they will. They're the kid, they can ask for whatever they want. They might ask for a whole plate of mac and cheese. They can ask for, you know, 10 ponies and a rainbow, like whatever they want. So, but you're the parent, you decide what gets served. So, you know, what they get and what they want might be two different things. But definitely important to serve foods that you want your kid to eat. So this is very important. I hear this from parents a lot. My kid doesn't like X, Y, and Z. And then I ask, well, when was the last time you had X, Y, and Z? Oh, we haven't had it in months. Oh, we had it last year. And I was like, well, you need to, try and expose your child to foods a little bit more often, because kids, like adults, need a little bit of practice to learn to like new things. So really, trying to get them exposed to different things, or even to the same food or fruit or vegetable over and over again, is really going to increase the probability that they're actually going to try it and maybe even like it. And making food and eating fun. This is more for younger kids, especially when you're trying to get picky eaters to try new things. Using fun utensils, shapes and colors, cookie cutters, things like that can really just make, trying a new food fun. Talking to kids about food, we really want to focus on what foods do for us, not necessarily whether they're good or bad. So promoting a healthy weight and healthy relationships with food. I want to touch on this just because, obesity and weight is such an important topic to talk about with bone health too, because weight has such an impact on bone health. So I think it is important to talk about how do we build healthy relationships with food, and of course, how do we promote healthy weights. So some do's. So do's are focusing on the things that foods do for us and the good things that foods do for us, and trying not to assign a value to the foods. So, kids do pick up on, our ideas about foods, our ideas about a lot of things. So trying to focus on what foods do for us and the good things helps them to really encourage them to try those foods. Focusing on health behaviors, not necessarily weight. So we don't want to, have too much of a weight-focused approach. We want to have an approach that focuses on the healthy behaviors that promote a healthy weight. And encouraging these and making it easy for kids to make the better choice. So that includes minimizing screen time and electronics. If you do this, they have no choice but to do something else with their time. Of course, minimizing sugar sweetened beverages, promoting water and milk consumption, and eating as a family whenever possible. And then some don'ts. So, talking negatively about weight or body size or shape, your own or your child's, even if you never make a comment about your child's weight or anything related to their shape or size, talking about your own shape or size has, research has proven that this can negatively impact a child's opinion or view of themselves and their body size and shape. So, very important to kind of leave our own opinions about body shape and size out of things. Don't bribe, coax, or nag your child to get them to eat the foods that you want them to. It will backfire. So just trying not to, do that, trying to avoid doing that is definitely a better practice. And then telling children that they should eat less or that they shouldn't eat that. I mean, this seems obvious, but I have heard from parents sometimes that they will, make comments like this. So I think it is important just to kind of reinforce, our opinions about what our kids should or shouldn't eat. Try and keep them to ourselves, and really, again, this concept of making it easy for kids to make the right choices at meal times. Obviously, don't use food as a reward, and don't put your child on a diet unless medically indicated and supervised. So some nutrition for bone health. So what are our major considerations for bone health? We, of course, are going to talk about vitamin D and calcium. We're going to talk about RDAs, so how much we should be getting of these nutrients every day, good food sources of these nutrients, and why exercise is important for bone health. And I know Dr. Minkowitz will talk about that too. So what is calcium? Calcium is a mineral. It's found in food. It's found in supplements. It's found in multivitamins, makes up the structure of bones and teeth, also has a function in the circulatory system. So in, blood vessel contraction and dilation, muscle function, also in nerve transmission and hormonal secretion. Vitamin D is required for calcium absorption in the gut. So you can kind of think of like vitamin D and calcium as friends. So they really need each other in the body, and it's very important that both of our stores and our intake of these are important for bone health. Our needs for calcium are actually determined by our growth velocity and rate of absorption. Adolescence, of course, is a critical period to achieve peak bone mass. So really, we'll see a little bit about this on the next slide, but those years from 9 to 18 and a little bit outside of that. So important to obtain enough dietary calcium, obviously, because if it's low in your blood, it's going to pull from your bones. So very important that we are focusing on getting enough calcium from our diets. these are the RDAs for calcium. So you can kind of see for babies, young toddlers, they're not crazy high, but once we get into the age from 9 to 13 years and 14 to 18, those are our critical periods for bone development. So our RDAs are going to be higher. So it's about 1,300 milligrams for kids in that age range. And then you can see as we get older, our calcium requirements are a little bit less. So very important for us to focus on that period between the ages of 9 and 18. So just some food sources of calcium and amounts. So I like to put this up here so we understand sort of like, what is one serving of calcium and where do we get one serving of calcium? So does anybody know what's one serving of calcium? What do we think it is in like milligrams? Does anybody know? 400? Yeah. About 300 to 400. So I would say about like 350 to 400 is considered one serving of calcium. So if you look on the slide, so I kind of separated into non-dairy and dairy. So, most of the foods which are going to be high in calcium are our dairy foods, but we do have some non-dairy foods which are high in calcium also. So calcium fortified plant-based milks also provide about 350 milligrams per serving, 8 ounces. Calcium fortified orange juice also does. Some other non-dairy sources are tofu, of course, and cooked greens, spinach, and kale. Yeah, I agree. And that's kind of why I put this slide on here. So, we can think about what is a serving of calcium? Where are we actually getting a serving of calcium? A cup of milk, that's only 300 milligrams. So you'd have to really have at least 4 cups of milk in a day to hit your, sort of like your calcium needs. So, on the next slide, I actually put together what does 1,300 milligrams look like in a day. So for the orange one is including dairy and the gray one is non-dairy. So you'd have to have at least a cup and a half of milk, a cup of fortified cereal. You'd have to have 2 ounces of cheese. That's like a couple of cheese cubes, half a cup of yogurt, and half a cup of cooked spinach. So that's a lot. Yeah. Yeah. So that's why I always tell kids and families, you have to be a good label reader, Yeah. Yeah. So, and you can see in the non-dairy version, it's kind of equally difficult to get enough calcium in a day, or you have to be very conscious of it. So 1.5 cups of oat milk, you need a cup of fortified cereal, you need 4 ounces of orange juice, you need half a cup of tofu, and 1 cup of cooked spinach. So they both kind of equate to about the same, but again, it is important, I think, to understand what 1,300 milligrams looks like in a day. Factors affecting absorption. So plant versus dairy calcium. It's the same form of calcium, but different absorption. So we absorb calcium from dairy a little bit better than we absorb calcium from plants. This is because of the presence of so-called anti-nutrients. I don't love that phrase, but that's what they're called: oxalic acid and phytic acid. So these kind of interfere with our absorption of calcium. So if they're present in plant foods, it just means that we can't absorb as much of the calcium in plant foods as we can in dairy foods because they're not present in dairy. So a solution can be to cook them, boil them, or soak them. So this is really only a concern if you, I would say, don't have any dairy in your diet, if you're vegan, if you're vegetarian and don't consume dairy foods. But if you're consuming a well-balanced diet, if you're having some dairy foods, some non-dairy foods, not necessarily a concern. So
And I usually say, just consider that the extra and try to get your numbers, some other way, even if it's supplement. You do what you got to do. Calcium has to go in the body.
Yeah, I was going to ask about, I don't know if you're going to address that, but calcium supplementation.
Calcium supplementation? Yeah, I can talk about it. Vitamin D status, another factor affecting absorption. Calcium requires vitamin D to be absorbed in the gut. So of course, you could be taking in 1,300 milligrams of calcium in a day. If your vitamin D stores or status is not optimal, you won't be absorbing all of that calcium. So very important to consider that as well. Decreased protein intake. Your body needs protein to absorb calcium as well. Not necessarily as something that all of us struggle with, but sometimes for picky eaters, for kids who don't necessarily like a lot of foods, making sure that they have adequate protein is something to focus on. Increased sodium intake. I'm sorry for the typo there, but increased sodium intake, sodium and calcium do compete for absorption. So if you have a lot of sodium in your diet, if you're having higher consumption of higher sodium foods, something to think about with calcium absorption too. And of course, age, we're going to absorb more calcium depending on what age we are. So actually in infants and young children, our calcium absorption can be very high, almost 60%. In adulthood, it can be as low as 25%. So, your body's very smart. It knows if you need more calcium, if you're building bones, it will absorb more from your diet. If you don't need as much calcium, it will not absorb as much. So some tips to get more calcium in. Choosing milk or smoothies made with milk instead of juice or soda. Serving kids a glass of milk with breakfast or dinner every day. This is probably the easiest thing that parents can do to promote calcium absorption. It's just a routine. You serve a kids a glass of milk with either breakfast or dinner or both, and that way it ensures that they're getting an easily absorbable source of calcium almost on a daily basis. Can add cheese or tofu to salads, or have individually packed cheese or yogurt for snacks. Add yogurt to pancake or waffle batter or smoothies. And then, of course, if you do not consume dairy, aim for 2 to 3 servings of dairy or their non-dairy equivalents per day. And I don't have a slide on here about calcium supplementation, but I'm happy to answer any questions that you guys have either now or at the end of the presentation. There's not much in it, yes, and calcium and iron also I wanted to mention. Calcium and iron, sort of like calcium and sodium, can compete for absorption. So if you have a multivitamin where iron is present and calcium is present, one of those things isn't going to be as easily absorbed or as well absorbed as the other. So really depends on, if a child's taking multivitamin and they're not getting a lot of calcium in their diet, yes, calcium supplementation can definitely be something to consider. So, but think back to like my slide on the RDAs. Where's the RDA hiatus in 9 to 18 years? Those are our prime years for building bone mass. So yeah. On to vitamin D. Of course, vitamin D, fat soluble vitamin, found in food supplements. Multivitamins also produced endogenously through exposure to UV rays. So we produce it when we expose our skin to UV rays. So, it takes approximately 5 to 30 minutes daily for us to get our, intake of vitamin D. So face, arms, hands, legs need to be exposed. Functions of vitamin D, of course, promotes calcium absorption in the gut. It's needed for bone growth and remodeling, and also has neuro and immune functions as well. There's 2 main forms, ergocalciferol and cholecalciferol. They're both pretty well absorbed. And of course, when we say fat soluble vitamin, we mean that vitamin D is better absorbed with a fat or in the presence of fat. So fat enhances vitamin D absorption, but if you don't have any fat in your diet when you take vitamin D, your body still will absorb some of it. So, I know sometimes we think about, vitamin D and fat soluble vitamin. Oh, well, if I don't take it with fat, I might not absorb it. Your body still will absorb it. It's just going to be absorbed better in the presence of fat. So RDAs for vitamin D. So you can see, this is from the IOM, so there are some different, which Dr. Minkowitz probably will talk about, different recommendations for basically the recommended intake daily for vitamin D. So the IOM states that, or IOM guidelines are about 600 international units or 15 micrograms per day. And we'll talk a little bit more about that. Yeah. So food sources of vitamin D and amounts. So there are not very many foods which contain vitamin D. So, what actually are our vitamin D rich foods and how much vitamin D do they really provide us? So cod liver oil sounds great. Good luck getting any kid to eat that. Provides us with about 1,300 international units of vitamin D a day. So if you have a kid who will eat cod liver oil, God bless you. But most of us do not want to eat that. So, trout, sockeye salmon, so our fatty fish, those are really going to be our only main, good sources of vitamin D, providing about 600, give or take, international units. Mushrooms exposed to UV light also provide us with a little bit of vitamin D, 366, but, really not very much at all. And then 1 cup of vitamin D fortified milk gives us about 120, large egg, 45. So what does this look like in a day? So what would you have to, even meet the minimum requirement of vitamin D? We'd have to have 2 cups of milk, 2 whole eggs, and a cup of mushrooms if you don't like fish, or you can have 1 serving of fatty fish. So, very difficult. Yes, they're very difficult to find. So the only time I've ever seen mushrooms exposed to UV light is at Whole Foods. So at Whole Foods. Yeah. So they actually, and I don't even know if they're in the regular packaged mushrooms. I know that some stores have a mushroom, it's sort of weird. It's like a mushroom cabinet with UV light. So those mushrooms will contain vitamin D. But And sometimes if you do find mushrooms, like packaged mushrooms in the grocery store, some of them will say exposed to UV light. They'll always tell you whether they're exposed to UV light. So if you go into the grocery store and see a package of mushrooms and it doesn't say it on there, assume they are not exposed to UV light. But they do produce some. But again, it's, it's not super significant, I would say.
And this is to hit 600 micrograms per day, which in my opinion is 1,000 behind anyone that's up to 90 pounds. And then it's 2,000 behind. So this is minimum.
Yeah, and keep in mind that, that the IOM actually updated their recommendations in the last, I think, year or two. It used to be 400 and now they've updated to 600. So
but the dermatologist wants at that. And you're not going to get any food. It's going to be virtually, unless you're a tiny little kid might get enough. The sun, the other problem is just because you can make vitamin D in the sun doesn't mean that you can make vitamin D in the sun. I've seen sun worshipers don't wear sunscreen and they can't bump their vitamin D level. So if your assumption is that you're going to make vitamin D in the sun, that may not be true anyway. And you have to be below a certain latitude to even have enough sun over the year. You have to be New Orleans or below in the United States.
I'm one of those people. Like I bike and I'm outside and my vitamin D is always there. Like, you got to bump it back up. And I'm like, and I'm outside.
You're outside. So you're in New Jersey. Maybe you do better by the equator, but you may not. You just don't make vitamin D.
I just don't.
And that's it.
yeah,
But I feel like we're of the mindset, like, as an old lady, we're very cognizant of, we think about calcium and vitamin D in the right balance, where you want enough for your bones, but you don't want heart calcifications, but,
It just did it.
but you don't really think of it so much for kids.
Yeah.
Calcium supplementation or vitamin D supplementation, you don't really hear about it.
Right. And you should. You should. But
Yeah.
because the IOM said he's set the bar so low and people don't want to be confrontational, they're willing to let everybody continue to take very little. It doesn't work in my practice because I actually check people's levels. I need their practice. So I set the bar much higher and I can validate it by checking people.
I don't check them with kids or check the vitamin D levels.
Good
and I was like,
question. Good question.
It is a good question, and I always, like, my quarters, we actually had a girl years ago, and she down the back, she was so sick, depressed, the whole thing. It was so low. And so after that, I had all my kids tested, and the last time, recently, like 2 years ago, they started to back, they said it's not a routine.
Right,
They
that's
test
the
anyone.
I'm thinking of.
They wanted it,
That's something they want.
doctor had to document why it was done.
See, that's wrong.
Like, totally wrong.
If this country would mobilize itself and say, you insurance companies, you pay for this because we want our population healthy, it would happen. Look at all the COVID testing. I mean, come on.
Right.
This is a lot more important.
Yeah,
At this point, it is.
Yeah.
But
Yeah.
I have some slides like that. You'll see when we get to my talk.
yeah. So I put this slide together so we can really see, what is a realistic, are we really getting enough vitamin D from food sources in a day? And the answer is probably for most people, not even close. So vitamin D intakes and status, and I'm sure Dr. Minkowitz will cover this a little bit more. Many people consume less than the recommended amounts of vitamin D. Deficiency can develop when intakes are lower over time. Exposure to sunlight is limited, as it is in New Jersey at our latitude, and of course, absorption is inadequate. So signs of deficiency in children can be fatigue, can be bone pain, can be muscle weakness or cramps. Obviously, rickets is, a huge concern with vitamin D deficiency. So, knowing what the signs and symptoms are. Groups at risk of deficiency, so breastfed infants, those with conditions that limit fat absorption. So something to consider as well: Crohn's disease, celiac disease, ulcerative colitis. If you have vitamin D present in your diet, but you do have a condition that limits fat absorption, your intake of vitamin D might be compromised as a result of this. So definitely something to consider as well. Obese children or those with a higher body fat percentage can be at risk of deficiency, and those with dark skin as well. So, that can be a somewhat significant part of our population. Risks of excess vitamin D, of course, kidney and tissue damage, but that is only with very high levels. So to supplement or not to supplement, I'm sure Dr. Minkowitz will talk a little bit more about that, but, I think most people could probably benefit from supplementation. So. And then just briefly want to talk about bone health and physical activity. So this is a very vital ingredient to build bone health, and especially when we're talking about in pediatric populations, because I think inactivity is really a big problem now, especially with screen time. And of course with COVID, I think, with virtual learning, I'm sure we can all understand that kids have been very inactive over the past couple of years. So, this is not something to ignore. Muscles get stronger when we use them. Same thing applies to bones. So, any type of force, exacted or, got into bones is going to make them stronger. So what type of activities are we talking about? Really, any kind of exercise is great, but we want to focus on weight-bearing activity. So anything that's going to kind of like put weight on the bone, so running, jumping, hiking, dancing, anything where that bone is going to feel some type of impact, because that's going to make it stronger. And how much physical activity should kids really be getting in a day or in a week? So you can see these are the recommendations for different age groups. So actually for kids, it's an hour a day. So 1 hour, 7 days a week. For us, for adults ages 18 to 64, it's about 150 minutes a week. So that's about 30 minutes a day or 60 minutes on a few days a week. But kids really need much more physical activity. So every day, at least 60 minutes. And then activities that strengthen bones should be at least 3 of those days during the week. So that means on 3 of those days, kids need to be, kind of paying attention to what types of activities they're doing. So how to help your child kind of build their bone bank. Kids aren't always thinking about making decisions based on what's best for them. Maybe they almost never do this, but that's okay. Parents have a greater influence on them than you think. So being a good role model is something that I think is very important. This doesn't only apply to bone health, but also applies to all the healthy habits that we want our kids to sort of pick up and incorporate into their own lives. So incorporating calcium-rich foods into meals and snacks, and also eating calcium-rich foods yourself. This is very, very important. If a kid sees you drinking a glass of milk, they're probably going to want to drink a glass of milk too. So not something to, discredit. Helping kids find physical activities that they enjoy participating in. This is something I talk about a lot with families. So not every kid is going to want to do a team sport. Maybe they'll want to do an individual sport. Maybe they'll want to do a different activity. Anything that's going to get them active and keep them moving and get them off the couch and not looking at a screen is going to be something that is beneficial. Establishing a time limit for screen time and having everybody in the house agree on it, I think, is also very important. And then talking to your pediatrician about bone health, of course, like we were discussing, it's not always first and foremost on pediatrician's mind, but that doesn't mean that that's not something that you can bring up at your well visit or with your pediatrician to talk about. And of course, talking to your kids about their bone health. It may not be a priority for them, but it's okay for them, for you to let them know that it's a priority for you. And just some things to consider. When we're talking about nutrition, we're talking about building bone health, fostering healthy body images, all different things. They really have the same, it's the same means to an end. So practices that provide good nutrition to kids also build bone health, foster a healthy body image, and relationship with food. Some diets, when well planned, can be appropriate: gluten or dairy-free, vegetarian. Other diets are not appropriate for kids: keto, paleo, vegan. All of these different things are not recommended, and especially they are not necessarily beneficial for bone health either. So when looking for information online, because I know I hear from a lot of families, information overload is very much a real thing. So when looking for specifically nutrition information online, I recommend going to websites that end in .gov, .edu, or .org. Typically, this is a very, reliable way to find evidence-based and accurate nutrition information. And when you're seeking out nutrition information or working with a dietitian, making sure that your nutrition professional is a registered dietitian, because we are the nutrition experts. And then, of course, if they have experience working with pediatric populations, that's a big plus. So 2.com websites that I recommend. These are like the only 2.com websites that I recommend about essentially like pediatric nutrition are Super Healthy Kids and Kids Eating Color. So they have great resources for not only nutrition information, but also recipes, and they're both run by registered dietitians. So 2.com websites that I do like. Those are my references. And any questions?
We can go back to Katie after this and go through some other, if you have any other questions for her at that time. So in my lecture, I'd like to establish a working knowledge of bone health, which Katie set the tone for that. Review the new literature so you can see just how incredibly important vitamin D is for various areas, and how to counsel patients regarding bone health, which we've already really started the discussion. So vitamin D deficiency, 70% of the children in the United States are either deficient or insufficient. And we've got increasing trends of vitamin D deficiency because, as Katie pointed out, where we've got a lot of sunscreen going on, there's less outdoor play, more clothes outside. 90% of your vitamin D is supposed to come from your skin, if you can make it, and we're not doing that. If you're very skinny, you don't have any place to store vitamin D. And then if you're overweight, then you need more vitamin D because it gets stored in the fat. Skin tone's important, as we mentioned. Now, peak bone mass. What is peak bone mass? Peak bone mass is when the child's body puts as much bone as it possibly can, and as much calcium as it possibly can into the bone, and it usually is done by the time you're 18 to 23 years of age. So, as Katie pointed out, starting at about age 9 or so, as you hit your adolescent growth spurt, you need to be getting all those supplements into your body so you can make some decent bone, so you don't end up in a situation where you don't have good bone. There are things that you can change with regard to your bone health: exercise, nutrition. We talked a little bit about breastfed babies needing extra vitamin D because of the either none or very little vitamin D in the breast milk. The calciopenic kids, the kids that get no calcium in their diet because they're lactose intolerant, they've got milk allergies, they just don't like calcium food. The diets that exclude vitamin D, such as the vegan diets. There are things you can't change: chronic conditions, diabetes, cystic fibrosis, asthma, malabsorption, aging and hormones. You need more as you age. When you don't have hormones around, that affects your bone health as well. And then medications can reduce absorption of vitamin D. Exercise is important, as we were just discussing. There's something called Wolff's Law. Wolff's Law says that bone grows and remodels according to the stresses on it. And that's related to the quality and the quantity of the stress. So there's a study that showed in children, exercise plus calcium led to bone accrual. They were making bone. Adult exercise, walking briskly, running, strength training, increased bone and decreased loss. There was decrease in fracture risk and fall risk. High demand athletes, those ones that are very skinny because they're, the runners especially, that are just, very, very thin, are at risk for osteopenia and amenorrhea in the girls. And this will then cause bone mass reduction, and that's, affecting their internal hormones. There are trends towards teens with decreased activity, especially with the pandemic. I try to keep my kids as active as possible in the office. Even if they're hurt, I try to find something they can do, just so they're not sitting around. Sports medicine update: weight-bearing sports, just like we were talking about, weight-bearing activities, judo, volleyball, soccer, increase bone mineral density in the lower extremities versus non-participants and non-weight-bearing athletes such as swimmers. Your non-elite level weight-bearing exercise has positive effects on calcaneal bone, so that's the heel, versus swimming or cycling. So swimming and cycling, they're great, they're cardiac, you're burning calories, you feel good, but you need a mix. You can't just swim and cycle. You need to weight bear as well, walk, something like that. There's a national study of high school sports that talk about stress fractures. And basically, you have 2 times the rate of stress fractures in females versus males. And you see it mostly in cross country and gymnastics activities. 75% of them are in the lower extremity. And when these kids come in, the first thing I do is say, okay, we're going to treat your stress fracture. Get me a vitamin D level. Let's check your labs. Because if you let them rest and feel better and then they go back out and they haven't changed what they're doing, it's going to come right back. Now, I've decided that the way we need to look at this, which is, what Katie was talking about is you need a supplement recipe for bone health. Okay, it's not just one thing. You need the recipe so that you can make good bones. You can't just say, okay, took my vitamin D, I'm good. No, the vitamin D moves the calcium in the body. If you just take vitamin D and you don't put calcium in your body, it will move it around your body. If you're low, you're going to get something called hungry bone syndrome, where your bones are going to hurt, your joints are going to hurt because you're taking vitamin D and there's no calcium. You need things such as boron to help stabilize and extend the half-life of vitamin D, and some silicon and some estrogen. Vitamin K is needed to build bone. Vitamin C to make the collagen architecture of the bone. And then the calcium, you need to put that into the bone to make it strong. And vitamin D deficiency, as Katie was saying, you get aching, weakness, fatigue, you get joint pain, muscle pain, and spasms. These kids that come in with back pain, I need their vitamin D level. I can't fix somebody that tells me they've had 2 years of back pain unless we look at the whole patient. Weight gain, depression, you need to look at their vitamin D. And it kills me when the psychiatrists put these kids on medications and don't check their D level. It's a pretty simple thing to fix. Deficiency is linked with inability of mineralized growing bone, called rickets. In adults, when you lose it, it's called osteomalacia. You can get a secondary hyperparathyroidism, where you get, it's called proximal muscle weakness. So the bones that are close to your pelvis are weak, and that's when you're not as stable and you can fall. And it causes postural weakness. You see these kids that don't drink milk and they have terrible posture. They don't have the strength to pull themselves up. And inability to reach peak bone mass. We get delayed healing or non-unions in fractures. And then how much sun is enough? And we just heard about this. And I just put the latitudes in because I thought it was interesting, because we're at 40 up here. You have to be 30 or below. My daughter went to school in New Orleans, so she was at 29. And my son's in Miami, so he's at 25. But even so, do they spend enough time outdoors? No, because, Miami, it's too hot, it's too this, it's too that. They're working, they're doing. The focus is not on being out in the sun. And then we talked a little bit about vitamin D. So it's a steroid hormone that is stored in the fat. So important points to really take in is that the half-life is 2 to 3 weeks. So it only lasts for 2 to 3 weeks. Once you start taking it, you will reach a steady state by 8 to 12 weeks, which is why I always tell people to wait 2 to 3 months to get their blood level checked, because at that point you reach your steady state. And the graph on the side here is just showing you that, that once you've given vitamin D to people, you can see that you're reaching your half-life somewhere around 8 to 12 weeks. So vitamin D either comes in through your food or through your skin, and goes to the liver, where it gets it gets an OH attached to it. Then it becomes dihydroxy when it goes to the kidney, and that's your active form. So everything has to be working. Your liver doesn't work, your kidney doesn't work, you have a problem. So what is the goal for vitamin D in the serum? Well, the Institute of Medicine, like I said, they set the bar very low. They say that you're deficient if your vitamin D is less than 12, okay? The Endocrine Society says, well, we don't want anyone less than 20. And we would consider anyone deficient under 30, whereas the Institute of Medicine says, well, if you're in your 20s, you're okay. I would agree with the Endocrine Society based on my experience with children. They don't heal well in the 20s. 30, according to the lab, is normal. Anybody who hits 30 and above. I like to see people between 40 to 60, because this way they gain weight, they lose weight, they're going to stay in a good place. And that's what we need. Bone health workup, we do labs. I always check a CBC and a CMP, make sure you're not anemic, make sure your kidney and liver work. And then, check your vitamin D, you can check the phosphorus and the PTH. The calcium is part of the metabolic profile. I always use a vitamin D deficiency code, and I don't have people complaining that it's not paid for. I don't have any scruples about saying that my diagnosis is vitamin D deficiency because most of them will be vitamin D deficient. So I'm fine with that. Vitamin D has genomic and non-genomic effects. So just to put this very simply, the vitamin D can go into the nucleus of the cell and direct it, but it also has receptors not in the nucleus, and it can direct what it wants outside of that. And it has many, many effects in the body, for the bone, not for the bone. We'll start out talking about autoimmune disease, okay? So when you talk about how people aren't getting checked for vitamin D, it kills me because there are these beautiful studies that talk about how you can reduce autoimmune disease with vitamin D. This beautiful study came out, it looked at vitamin D and omega-3 fatty acids. And what they did was they had 4 different groups. They had a vitamin D group, a placebo, a vitamin D with omega, and just an omega group. And it was amazing that that they could show that you can get a 22% reduction in autoimmune disease if you took both of them, and a 15% if you took the omega-3 fatty acids. And this is a 5-year study, and it was 26,000 people age 50 and above. So this is not this is like a real study, So this is important information because, this is, everybody knows somebody that's got something autoimmune going on. Now, what about MS? People have MS in the family. A low vitamin D is a risk factor for MS and for relapses. So if you keep your vitamin D up, or if you even just increase it 10 points in your serum level, you will decrease the chance of relapse by 20%. So, and this very nice study showed that people that genetically have good vitamin Ds really didn't have this problem with MS. Diabetes. How is it important for diabetes? Well, if you're a type 1 diabetic, early supplementation decreases gene expression. So basically, if you were giving vitamin D to infants and children and you have diabetes in the family, there's a good chance they may not express it. If you have type 2 diabetes, well, you need vitamin D for insulin release in response to glucose. So it reduces the overproduction of tissue damaging free radicals. So if you don't have it around, your insulin can't function properly. And, we know a lot of the type 2s are heavy people. Their vitamin Ds are really low. And again, why aren't we fixing everybody? Now, there's studies looking at cancer, and there was a vitamin D meta-analysis. So it looked at cancer and vitamin D and showed that if you got at least 1,000 to 2,000 units of vitamin D3, this would improve your survival and prevent cancers, including colorectal and breast cancer. So again, you want to keep it up. It's good for risk reduction. It reduces inflammation. Okay, it's an anti-inflammatory. It has effects on cell differentiation, progression, and apoptosis. It increases survival by reducing angiogenesis around the tumor and metastasis. Now, what about cardiovascular disease? So vitamin D receptors are found on the myocardium, and treating severe serum vitamin D deficiency improves cardiac muscle function. So vitamin D levels of 30 to 40 nanograms per ml are associated with a lower risk of MI and mortality in adults with no prior MI history. So again, another reason not to run low. People that have COPD, there's a vitamin D inverse relationship with COPD. So the lower your vitamin D, the more COPD you have. Inflammation may be a vital mediator of COPD progression in patients with low vitamin D. So that's important. And we have all these references at the end also. Dementia, okay? Vitamin D is important for neurophysiology and neuroprotection. It's involved in the synthesis of neurotransmitters, neurotrophins. It has anti-inflammatory and antioxidant effects and helps with the clearance of amyloid beta peptide. What about autism and vitamin D? Vitamin D improves symptoms of autism in 75% of children. And I've had people come to my office and I'll be like, why don't you give your child vitamin D? They're autistic. And the next time the parent comes back, they will tell me, I gave this one vitamin D, I gave that, and they see an effect. They're more alert, they're starting to talk. It's pretty amazing. Prevention of autism, how does that work? Well, what they showed was that if you supplement vitamin D during pregnancy, for the mother, obviously, and then for the infant in early childhood at about 1,000 IUs per day, this significantly reduced the expected incidence of autism for mothers with one autistic child from 20% to 5%. And again, let me just finish slide. Vitamin D is a neurosteroid. It's active in brain development, affects cell proliferation and differentiation, affects neurotransmission and synaptic plasticity. I think it's about 4,000. But one thing I want you to note is they're giving these babies 1,000 units a day. When people come to my office, I don't care what age the child is, I want them to take 1,000 IU drop. And I don't care if they're taking, some fluoride multivitamin that's got another 400. You're never going to OD people at that level. And I always say it's good for the bone, it's good for the brain, it's good for the immune system. So there is no downside in this time of COVID to giving them that. And then once they hit 90 pounds, I'm like, okay, 2,000. Fertility and vitamin D. Male and female fertility is affected positively by vitamin D. Pregnant and lactating women, the nutritional status of vitamin D during pregnancy can prevent vitamin D deficiency in neonates. You need vitamin D supplementation of 4,000 to 6,000 IU per day to have vitamin D in the breast milk. Now, does that really matter? To me, I would say no, because you can buy, 1,000 IU drop and give it to the baby each day, and then they're getting 1,000. If you're going to be depending on it to go through the breast milk, you have no idea how much they're actually getting. Like, that it can happen. What about illness? There's reduced risk of URI with vitamin D supplements. And vitamin D prevents or improves the symptoms of flu in infants less than 1 year of age. So they had 400 kids, and they showed there's a shorter duration of fever, cough, and wheezing in their high-dose group, which was, their high-dose group had 1,200 IUs vitamin D versus 400. And there was a low viral load in the high-dose group. So again, my feeling is everybody take 1,000. Like, what's the harm, COVID and vitamin D. So you have all these papers that came out that talk about how vitamin D deficiency is a possible risk factor for COVID. So everybody that has low vitamin D because they're on steroids, because they're obese, because they have whatever other problems, those are all the ones that got the worst COVID. So, there's something going on with the whole situation. And in September of 2020, there was a Spanish study that showed that there was improved outcomes after vitamin D supplementation in their hospitalized patients. There was increased severity and mortality in those patients low with vitamin D. The British Medical Journal recommended large dose vitamin D and gave the NHS staff supplements that included vitamin D, C, and zinc. A Newcastle hospital found large doses of vitamin D given to deficient patients had a quicker recovery and less mortality. And then an Israeli study in 2022 basically said the same thing. You correlate vitamin D deficiency with severity and mortality. And basically, if your vitamin D was less than 20, your mortality was greater than 20, your mortality was 2.3, versus if it was less than 20, your mortality rate was 25.6%. So that's a huge difference. Now, what about opioids and vitamin D? I thought this was interesting. Vitamin D deficiency strongly exaggerates craving for and effects of opioids, potentially increasing risk for dependence and addiction. UVB light causes skin to produce the hormone endorphin. This is chemically related to morphine, heroin, and other opioids. All activate the same receptors in the brain, and this explains some sun worshipers. It feels good to be in the sun. Transgender hormonal considerations. So administration of androgen suppressive therapy. So androgen blockade can severely affect bone mass. Addition of cross-sex hormones lessen the effect. It's not clear if the negative impact from the androgen suppression can be fully reversed, but there are studies that suggest that this has a neutral effect on bone over time. So it takes initially a big hit, but seems to come back. Orthopedic implications of low vitamin D levels. Vitamin D deficiency is found in children with lower extremity pain. So you come in for growing pains, I'm going to tell you to take vitamin D, and see if that goes away. Muscle spasms, I always tell people could be low calcium, potassium, magnesium, and I tell them they should take all that with the vitamin D. Low serum vitamin D levels are associated with pediatric fractures. There was a review and a meta-analysis of 13 studies that showed that low vitamin D was associated with increased fracture risk. Now, after the first fracture, the risk of future fracture is doubled, and the risk is further increased after the second fracture. So when these kids come to my office broken, I say, we need to change who you are so you don't keep breaking. You need to be someone else. You need to be someone healthy. Lower the vitamin D, the more likely you are to sustain a surgical fracture, and it's 6 times more likely if your vitamin D is less than 20. And that's a study that I did here in 2017. So the majority of patients that have a slipped capital femoral epiphysis are found to have vitamin D deficiency. A skiffy is when the top of the femur bone basically breaks through the growth plate and slips. And that happens because the connection isn't very good. And it's very often your larger child, the heavier kids. So 85% were found to be vitamin D deficient in this paper with 27 patients. And the time to healing was greater when they were deficient. Bone health and pediatric spine. So we get all these kids that come in with back pain. Okay, yes, it's posture, but you also have to work on their health. So up to 71% of children 12 to 17-year-old will experience low back pain at some point. The older they are, the more likely. And this is correlated to vitamin D deficiency, lower physical exercise, and a higher BMI. After supplementation, their postural balance improves. Spondylolysis is this little tiny break that they get at the bottom of the spine. A lot of the gymnasts do this. 77% of patients with spondylolysis are vitamin D deficient or insufficient. Vitamin D supplementation promotes bony union of the spondylolysis. So it may heal bone to bone. That's not really the biggest issue, but you want these people to be healthy. And you can imagine your gymnast is probably not taking supplements and all that healthy. So we need to push them to do that. Vitamin D protects against curve progression in adolescent idiopathic scoliosis. So this scoliosis is linked to vitamin D deficiency. Low serum levels correlate with larger curves. And I think what's happening is you have soft bone, it wants to curve, it's going to curve because it doesn't have structure. On top of that, you have poor posture, you're leaning on it, you're like saying, okay, get bad, I'm okay with it. Development of scoliosis is related to defective bone qualities and poor postural control. 30% are osteopenic with a 2-time risk of curve progression and surgery. You want to supplement them and you want to work on bone health. And there was this really nice study that showed that supplementation improves bone strength on high-resolution QCT scan. They had 330 kids, and the patients that had the higher dose of calcium and vitamin D only had a 16% curve progression versus the placebo group, which had a 48% progression. Effects of vitamin D supplementation on adult musculoskeletal health. So that's always a big controversy because there's so many studies done and there's no way to really compare them or add them together. And they're all different people and we don't even know if they're giving calcium with the vitamin D. But basically the bottom line is that when you look at all these studies, the only thing that's really significant is if you look at the subgroup of patients that have a vitamin D level of less than 10, who once you give them supplements, they have improved bone mineral density. And if you take this stance that you shouldn't test anyone's vitamin D, then you'll never find those people. But you have to assume that the people that aren't quite that low are going to do well with supplementation, not just for their bone health, but the rest of the things we discussed. Vitamin D and muscle. So vitamin D status affects muscle repair after injury. Vitamin D deficiency contributes to muscle wasting by promoting oxidative stress, favors production of free radicals within muscle fibers. Vitamin D supplementation might reduce muscle fatigue. It's inversely related to lactic acid. So, you got to build up of lactic acid when you're very active. If you have a better vitamin D, you shouldn't build up as much. Same with creatine kinase and total antioxidant. Muscle vitamin D receptors respond to serum vitamin D levels of 45 or greater. So you can't run a low vitamin D if you want to be a really good athlete. You want to improve your performance, your speed, your balance, your strength, your stamina. And then, the study, this is a very cool study. This was in 2011. They looked at the football players in the Pittsburgh Steelers. And what they did was they found that 26% had a vitamin D less than 20, 43% were between 20 to 32. So, that's more than half your group that are not at a good level. The black players had a level of 26 nanograms per ml. The whites were averaging about 37. More seasons were played by those with a higher vitamin D. Fracture rate correlated to the low vitamin D level, and contracts were not renewed in the deficient players. And now we have space travel. How cool is that? Space travel and bone health. So you may want to think twice about going into space. Space travelers lose up to 1 to 2% of their overall bone density per month. This is greater than 2 times the average adult loses in a year, okay? Microgravity environments, reduced loading, allow increased bone resorption with no change or decreased formation. Bone mass recovery after return takes 3 to 4 years. It's a worse problem for women who start off with a lower number. And you have increased risk of kidney stones, hip and spine problems, fractures, impaired healing. Exercise, nutrition, and pharmaceutical interventions are being tested, developed, and refined for use before, during, and after spaceflight. Osteoporosis. So this is considered something that starts in the 50s, but could be before that. It's a systemic skeletal disease. 54 million people in the U.S. have this. This is greater than 17% of the population. It's predicted to double by 2030. So we're going to have an osteoporosis crisis, but still, we don't check vitamin D levels. We got our head in the sand. Silent, costly, underdiagnosed, undertreated, and it starts in childhood. Prior fracture is the strongest predictor of future fracture. Greater than 30% of hip fractures had prior fracture. 80% are female. And, they believe it's underreported in males, so it's not that they don't have it. The incidence of fragility fractures is comparable to strokes, breast cancer, and heart attacks combined. So you want to ensure the patient takes enough vitamin D. So it gets back to what Katie was saying. So this is the RDA from the Institute of Medicine. And over here is the Endocrine Society, who promote higher levels, but still not all that high. But their levels are probably good for a lot of the children. What bothers me about the RDA is they think that everyone from age 1 to 70 should get the same amount of vitamin D without taking anything else into account. And as far as how you supplement it, it's sold as drops, pills, candies, mixed with calcium, without calcium. You can get 400, 600, 1,000, 2,000, 5,000, 10,000 units. So it's pretty easy to get them. So it's nice to know how the endocrinologist and primary care treat deficiency, because then it kind of makes you feel more comfortable with the numbers that we pick for treating patients. So if you come in deficient to an endocrinologist, they will give you a 50,000 unit pill once a week for 2 months or 3 months. And they should put you on a maintenance dose after that, but they don't always. If somebody's really bigger or whatever their reason, they can give them 100,000 a week. So they give 50 to 100,000 a week, which is the same as saying that they give 7,000 to 14,000 a day. They give D2 rather than D3 because that's what those pills come. The D3 is actually better absorbed and has a better half-life. So you're better off buying your own vitamin D than having them give you a pill. Vitamin D cannot be effective without calcium. We discussed that. You get this thing called hungry bone syndrome, which just makes you feel horrible. And I heard one person once say, yeah, my vitamin D was really low. I took vitamin D. It made me feel so bad. I must be allergic to it. No, you need to take calcium with it. So therein lies the problem. Calcium above age 3 is anywhere from 1,000 to 1,500 units a day. And I always tell people, you cannot get less than 1,000 a day. You just can't do that. You get up to 1,500. Do not get less than 1,000. So some FAQs. So can supplementation cause serum vitamin D levels to rise continuously and cause toxicity since it's stored in the fat? And that's a big concern for a lot of people. But it's flawed reasoning because, as I pointed out before, serum levels will reach a steady state by 8 to 12 weeks. Okay, whatever level they're going to, they will be there. And the half-life is 2 to 3 weeks. So it's not staying in your body for all that long. The goal for the Endocrine Society is 40 to 60 up to 100. There's a large safe zone. Basically, you shouldn't get toxic unless you're at least 240. And actually, the Mayo Clinic showed that they didn't find anyone toxic till they were like 350. But the zone of excess is an area where you don't need that much vitamin D, but it shouldn't do anything that horrible for you. If the level is higher than you like when you test it, then decrease or stop the supplementation temporarily and then add some back on. What is toxicity? So mega doses of vitamin D for extended period of time will give you toxicity. You can't get toxic from the sun. You must exceed serum levels of 240 nanograms per ml, not sure of the exact number. In a Mayo Clinic study, 1 of 20,000 people had toxicity at 364. And that person was taking 50,000 units a day for greater than 3 months. Monitoring serum levels is important. Poison Control reports 15,000 cases of overdose in 15 years. Only 3 developed clinical toxicity. No one died. They get hypercalcemic and they get stones, kidney stones, bones. The bones can bother them. Abdominal moans, so their stomach's bothering them. Psychic groans, they get headaches. Pediatric obesity. So we're going to talk about obesity a little bit here. So the prevalence of obesity in our population is about 18.5% in our children. Okay, so it's a pretty big number. 37% of those that were tested, I guess, they're probably not all tested, right, are vitamin D deficient. When you have increased adipose tissue, you have a decreased bone mineral density and a decreased bone strength. You have increased fracture risk due to decreased motor skills leading to falls and increased force generation. You're bigger. Fat releases pro-inflammatory cytokines, so you get a chronic systemic inflammatory state. This affects osteoblast, osteoclast, so your bone-making cells get affected and you get increased bone resorption in these people. Now the fat gives off leptin. This directly affects osteoclastogenesis and decreases bone increases bone resorption. Vitamin D modulates leptin and inflammatory cytokine production. So if their vitamin D was higher, they wouldn't make as much of that stuff. It's like putting a fire out. Vitamin D supplementation improves overall bone health, metabolic conditions related to obesity. So I'm in the midst of trying to get a study started to kind of validate what I've noticed taking care of these patients. So we want to determine an optimal vitamin D dosing based on weight, rather than say, okay, everybody gets 600, but we know vitamin D is sequestered in the fat. So why don't we just look at the size of the person, start there, and then fine tune after that? I mean, that makes sense to me. The problem is that there's a difference in vitamin D level by BMI have been recorded in response supplementation. So that means that, you know, if they give these supplements, they don't work on the higher BMI people. Vitamin D is fat soluble. Vitamin D storage in adipose tissue. So vitamin D is diluted in excess adipose tissue. So compared to controls, vitamin D stores were greater in obese individuals. There's a positive relationship between concentration of vitamin D in adipose tissue to serum vitamin D. The cause of vitamin D deficiency is volumetric dilution. So basically, instead of having a nice dark blue liquid in the first bottle, a lot of your vitamin D, you put the same amount of vitamin D in the last bottle, but you know that patient's got all this fat. It's going there first, and you've got a very light color there. So you really need more to get the same effect. Dose response of vitamin D, serum levels by BMI at 1 year of supplementation. So this is a nice graph that shows, and it's color-coded based on underweight, overweight, normal weight, obesity. It shows you that over the course of a year, if you give patients either 5,000, 10,000, 15,000, or 20,000 units of vitamin D, the highest their vitamin D level is, by 1 year later, is 80 nanograms per ml. So, you're under 100, and you're giving people these large doses. I don't usually give people these large doses, but it's an interesting study because I guess I do give people these large doses if they're large, but I don't give it to underweight or normal weight people. I would give them a lower dose. But it just goes to show you that it's not that easy to make people toxic, because you have to give them a lot more than 5, 10, 15, 20 per day. This graph is kind of interesting. People say to me, well, why don't you check my calcium, see if it's okay? Calcium is very homeostatic. So unless you're decompensating, your blood calcium level is going to be flat. So, I check it sometimes, like especially if I'm looking for some weird rickets or something. But I'm not usually that concerned. So things to remember, like I said, the RDA for vitamin D is 600 units, too low. Endocrine Society gives you a range 400 to 4,000. That's too low for your heavy patients. The half-life of vitamin D, 2 to 3 weeks, steady state by 8 to 12 weeks. So if you administer a monthly vitamin D, it's not going to work. And I have patients come to me and go, oh, well, we take it once a month. But it only lasts 2 to 3 weeks. So when you get to week 2, it's already dipping. By the time you get to the end of the month, you're low. So why wouldn't you do it weekly so that you can keep yourself level in terms of how much vitamin D? So I like daily, but I'll go with weekly because it doesn't matter. They're both fine. We know vitamin D is stored in the fat, therefore weight and BMI affect vitamin D dosing. So, our goal is to keep the serum levels 40 to 60 up to 100 in these larger patients aged 6 to 18. And I had a 140-pound 6-year-old, okay? Like, these are big children. This is needed. We need an effective, simple, safe algorithm for the community so they can go out and buy what they need. We need a prospective study so that we can validate it, okay? Validate an effective empiric maintenance dosing by weight, testing the serum level before and after, which will be hard to convince kids to let me do that. But, and I know these numbers work, but I need to actually, for me to go out and tell the world, this is what you need to do. We need a study like this to show scientifically this is what we're going to do. So I like anyone from birth and up to get 1,000, okay? Definitely 50 to 90 pounds, okay? 1,000 over their multi. So they're basically getting 1,400. Age 90 to 140 pounds, I go with 2,000. And then I go with 5,000 at about 150 pounds to, I don't know, maybe 180, 190, and then go to 10,000. And then I operated on a kid yesterday, 230 pounds. Now, I think he's getting 10,000 a day, and his vitamin D is only 34. So 230 pounds, I really need to be pushing 15 or 20 if he's on 15. I don't know what he's on. I just know he's huge. This is daily. These are daily numbers, but you are losing all that into the fat. It is not doing anything for your serum level. So in summary, children with fractures, any orthopedic issue is an opportunity to discuss bone health. We do that every single visit. Vitamin D is important for everything and everyone. Make sure you're taking enough. Thank you. And we can have questions. And Katie, you want to come up?